Not infrequently, we are called into the neonatal intensive care unit to perform percutaneous emergent cystostomy to allow for decompression of an obstructed renal system that is obstructed at the level of the urethra. This is most commonly seen in neonates with urethral atresia, severe posterior urethral valves, and this is normally performed in the intensive care unit with sonographic guidance. And then when the child is more stable, they can come to interventional radiology for fluoroscopic studies. Again, this is best performed with a single entry 4 French U sheath needle system. We would usually use the 8 to 9 megahertz curvilinear or phased array transducers. Again, the 4 French sheath needle will accept the 0.35-inch guide wire, and then we can dilate up and place a 6 French locking pigtail drainage catheter. Here we see this single-step approach with a bladder and needle introducing lidocaine, local anesthesia into the bladder wall, the needle indenting the bladder wall, needle entering the bladder with a single puncture. Now with the sheath in place and the needle removed through that sheath, we can then place the guide wire into the bladder under ultrasound guidance and then place our drainage catheter over that with dilators as necessary. Now we have the bladder catheter in place, and then with that in place later on we can perform fluoroscopic studies. This was a patient who had a urethral rupture due to trauma, and we had to perform the urgent percutaneous cystostomy. Now remember that some children, as in this small neonate with urethral stenosis, with a high-grade stenosis, the patient still has the ability to void, and so we must work quickly. Here we see the bladder with urine in it and the needle in place, but as we place the guide wire, the patient then empties the bladder with voiding. Once we have the guide wire in place, then we can successfully advance dilators and place a 6 French catheter into the bladder. And then in very small children, a 5 French catheter is another alternative. Once the catheter is in place, then we can add saline to stand up the bladder to ensure that we are in excellent position. Once the catheter is in place using an anterior suprapubic approach, then we can bring the patient down for fluoroscopic studies. And as we see in these two frames, in the bottom right frame, the urethra was successfully navigated with a guide wire, and then a second catheter was in place using a transurethral approach. Not uncommonly, patients with ventricular peritoneal shunt catheters will develop failure of peritoneal resorption of the cerebrospinal fluid and develop a cerebrospinal fluid pseudocyst. We are now being asked to support the neurosurgical care of these patients with a drainage procedure and technique that we developed at Nationwide Children's Hospital. The surgeons have a need to assess the patients for infection and see if they need to revise the shunt emergently. If there is no infection in the fluid, the neurosurgeon can then electively revise the shunt, and then our position is to help the neurosurgeons define urgency for surgery with ultrasound-guided drainage of these fluid collections. Again, similar story as before, usually a 5 French coaxial needle and sheath system. It will be all that we need, or if you prefer, you can place an 8 French pigtail drainage catheter for an in and out drainage procedure. We then will drain the pseudocyst and pull out the catheter, send the fluid for microbiological analysis. If there is sterile fluid and no bacteria with gram stain, then the patient can go home, or they may even be sent home anyway, and the neurosurgeon will follow up by telephone. Note is made that less than 5% of these patients are ever infected, and they can then be supported with non-urgent revision of their shunts. Here we have a CT scan with a large CSF pseudotumor with the ventricular peritoneal shunt catheter in the center. Same issue with ultrasound. The arrow is on the ventricular peritoneal shunt catheter in the CSF fluid collection. Here we have the 5 French U sheath needle system in place. As the needle comes out, we see the side holes of the echogenic tip of the polyethylene sheath that works very nicely. And in this case, we put an 8 French drainage catheter and drained the fluid collection. Here's the fluid collection before we begin drainage. Now we see the drainage pigtail catheter within the decreasing fluid collection. And then the arrow points to the 8 French catheter, and then we see that the catheter is now within this very small remnant of the CSF collection before we remove the drainage catheter. So with ultrasound guidance using a supra-umbilical approach, we will then place the 5 French needle and sheath. Here we see the cerebrospinal fluid coming out, guide wire in place, dilator in place, 8 French catheter. And if we're dealing with a large fluid collection, note is made of the long time that it takes to drain this fluid if we're using a simple syringe aspiration technique. So then the question arises, how do you drain 2 to 3 liters quickly? Well, the answer is you connect your drainage catheter to an adapter system and use vacuum suction. And this will help you facilitate drainage, again, either through simply a 5 French coaxial sheathed needle and catheter system or an 8 French pigtail catheter. Then we will connect that to wall suction. Here we have the adapter connected to the catheter lure lock system, and then using a blunt connector system that is then connected to the vacuum drainage system. The other end of the vacuum drainage tubing is handed off in a sterile fashion to the technologist, who will then connect it to the drainage containers and begin vacuum suction or wall suction. Here we see 2 liters of fluid drained from this patient. After drainage completely of the fluid collection, then we'll remove the catheters. The last topic that we'll discuss is the rare situation in which we are asked to perform ultrasound-guided foreign body removal. And critical techniques that we utilize for this: first, the 3 frames on the right illustrate the hydrodissection using lidocaine with a 23-gauge needle. Here we see a wooden foreign body in place and the needles with the injection of lidocaine. The arrow here is indicating the lidocaine injection surrounding the foreign body, and then 2 other arrows demonstrating how the lidocaine will track as it dissects the tissue away from the foreign body for removal. Then we'll use tactile definition with forceps under ultrasound guidance, and again we can use the 23-gauge needle to contact the foreign body prior to introducing the forceps. Then with forceps we can perform blunt dissection, and if there's granulation tissue or scar tissue surrounding the foreign body, we can perform sharp dissection using a number 11 scalpel blade under ultrasound guidance. In our experience of now performing over 600 foreign body removals in a 14-year time frame, we have better than 98% successful removal of these soft tissue foreign bodies and occasionally intratendinous and intraosseous foreign bodies with an average size of the incision of 5 millimeters. You can see that we remove these anywhere from the face, the orbit, the neck, the legs, the arms, and the trunk. The 2 instruments that we use: first, top we see the Kelly forceps, the small Kelly forceps, and at the bottom the alligator or Hartmann forceps. Both of these are used with great advantage. This is one of the 2 emergent situations that we've encountered, and again with 600 cases we've only had 2 times where we've had to come in emergently to remove the foreign body. This is a 13-year-old girl who has a fragment in her right chest wall that is causing pain. Her mother was cutting grass and she felt something hit her side and caused recurrent pain. On CT scan you can see there is a metallic fragment that is in an intercostal position, and every time she breathes she feels this irritate her abdomen, and the surgeon was alarmed to see that this is precariously up against the liver edge. And with bone windows we can see this is immediately adjacent to the liver capsule. And so the surgeon asked if we could support the patient with ultrasound-guided foreign body removal. Here we see the subcutaneous tip of this large metallic piece of metal fragment. And then looking more deeply, we see the tip of the metal fragment immediately adjacent to the liver edge, only 2 millimeters from the liver capsule. And here we see the frame with the needle in place for hydrodissection, with lidocaine being administered surrounding the tip of the foreign body. Now we have 2 arrows illustrating the forceps teeth being brought in to grasp the foreign body. As we remove the foreign body, we follow the foreign body and make sure that the distal end is coming out without any fragmentation. And then following removal, we will interrogate the field as well. A second patient was developmentally developmentally delayed patient with sepsis in the intensive care unit. If you notice, the intensivists were trying to gain vascular access using a left femoral approach and ran into difficulty and took this radiograph with the needle in place, and they noticed that they had lost the guide wire and they had some difficulty placing the guide wire and needle access. As they removed the needle, they noticed that they had sheared the guide wire off and that it was embedded somewhere in the perivascular location. They called us to not only localize it, but assist in ultrasound-guided foreign body removal of this vascular guide wire. Here we see the arrow pointing to the guide wire that is embedded in a subintimal location. So it entered through one wall, exited the lumen, and entered the subintimal location. And we can see in this frame how the guide wire is exiting the vascular lumen. The arrow now is on the forceps that are coming in under ultrasound guidance to grasp what is left of this guide wire with control and then remove it under sonographic guidance. So in conclusion, hopefully this discussion illustrates some practical aspects of emergent and urgent utilization of ultrasound, both in children and in young adults, when interventional radiology care is required to support the patient, and in situations where sonography gives us unique and critical advantage for not only precise and elegant technical care, but also excellent care that supports the patient and allows for a very successful care team and successful care partnership for the patient's benefit. Thank you.